Okay, so thank you very much for the invitation to speak. I was asked to talk about why clinical trials matter in low and middle income settings, and I've chosen to talk about the context of Africa. These are my disclosures. So the question about why think about Africa. So there are a few things that we have to note. One, our population is fairly large, 1.4 billion people. And then again, the growth is expected to be quite significant over the next 5 to 10 years. And despite this, and despite having majority of the burden of infectious diseases, for example, if we look at the reports around global burden of disease, about 25% is borne by the African context. And despite that, only about 2.5% of clinical trials take place in Africa. And I'll give you an example of something that's outside the context of HIV, and this is the issue of antimicrobial resistance, which is a big burden globally and a big burden for us in Africa. And looking at this data that was published by Lancet about sometime last year, we look at the mortality associated with antimicrobial resistance. And to the left of that chart, we see that the highest burden is in countries in sub-Saharan Africa, Western sub-Saharan Africa, Eastern sub-Saharan Africa. And despite that, there's no clinical trial looking at new antimicrobials in that context. So we are dying of diseases that we cannot treat, and no clinical trials will come to this context. The other thing is that highest disease burdens mean that interventions towards those diseases should be targeted and should be relevant to the populations in which they occur. And that chart really looks at the growth in research activity in Africa, which has gone up. But despite having gone up, it's still a very small percentage of the clinical research that actually takes place in this context. So we have significant genetic and environmental diversity. We have a large patient population, which means patient recruitment can actually happen faster in this context. But we also have demographics that have otherwise not been represented in HIV clinical trials. Today we've heard about HIV and aging, for example. We have very little data on aging in our context. Some of the challenges that have been thought to affect setup of clinical trials in our context include things like limited clinical trial infrastructure, limited lab infrastructure, and maybe the whole issues around regulatory and ethics committees. And in the next slides, I'll give you a few examples of clinical trials that we've done and how we managed to go over this, just indicating that it is possible for us to do more clinical trials. So the first example I'll give is from the 2SD trial. The 2SD trial was a multi-center trial that we carried out in Kenya and enrolled patients between February and September of 2020. We actually started enrollment 1 month prior to COVID knocking into Kenya, so we ended up enrolling most of our population during the context of COVID. And what we looked at in this population, I'll just go back one slide, we looked at a population of patients who are on second-line PI regimens, and we had significant concern about this population because, particularly of TB, we did not have options for treating TB in these patients because we did not have rifabutin at the time. Many of our patients already on atazanavir, so rifabutin was not an option. And we randomized patients to either DTG and 2 NRTIs or could continue their current PI. And over a period of 48 weeks, we managed to show that this was non-inferior and it was also safe. And this data has actually now informed the IIS US guidelines, the BIVA guidelines, and our own national guidelines. The other study that I just wanted to highlight is something that we are currently conducting, what we call the BFTAF elderly study, and we've just had the issues around aging with HIV. And this is a trial in which we are enrolling participants above the age of 60. We've enrolled about 520 participants, switching them to either BFTAF or continuing with their current antiretroviral regimen. But there's some lessons that we've learned about this in the context of carrying out this trial. One, a large proportion of our participants had renal insufficiency. Actually, the main reason we excluded participants from the study was because about 35% of them had creatinine clearance below 60. We also found, looking at DEXA scans, that about 60% of our participants had osteoporosis, which is a lot higher than has been described in studies in other contexts outside of Africa. We also found that the tools that we look at assessing fracture risk, like the FRAX tools, were not relevant to the Kenyan setting because they did not identify participants at high fracture risk. risk. So this study has given us opportunity to study a population that's very underrepresented in many clinical trials, but also that is very relevant because a large proportion of our patients are aging now. Many times there's a talk around not having the right clinical trial infrastructure. And we are currently participating in the Impala study, which is looking at long-term injectables, so cabotegravir and rilpivirine every 2 months, and is part of a number of other contexts that are also doing this study. When we started out, we had issues around cold chain requirements. So we've had to go out and buy fridges and set up air conditioning. We've had to do a lot of training for our medical personnel just so that we could get ready to conduct this clinical trial and learning the lessons around ensuring that our context can actually carry out clinical trials. So just to conclude, one, I would like to say that it's no longer enough to rely on data from elsewhere. We have a different demographic of patients, but we also have the knowledge and the will to conduct clinical trials. And lack of capacity should no longer be an excuse. Let us set up the capacity, let us set up the clinical infrastructure, and let us leverage on each other's strengths as much as is possible. Thank you very much.